One of the most striking differences between niacin and its designer NAD, boosting cousins NR and NMN, is the scale of dosing. Therapeutic niacin doses used in clinical trials and lipid management commonly range from 1,000 to 3,000 milligrams per day, levels far beyond typical daily vitamin B3 needs, around 15 to 20 milligrams. By contrast, NR and NMN supplements are marketed with recommended doses in the 100 to 500 milligrams range, or even microgram quantities in some cosmetics or specialized formulations, and they're often promoted as more efficient or potent NAD precursors because of their much lower dosing requirements. This superficial contrast has fueled the perception that niacin's need for high doses is inherently a disadvantage, but the reality is far more nuanced, and in many ways, higher dosing reflects niacin's greater therapeutic leverage. First, it's important to understand why niacin requires grams per day for therapeutic effects. It's not only being used as a vitamin to correct deficiency, but also as a pharmacological agent to modify lipids, reduce inflammation via GPR109A, and drive systemic NAD repletion. These actions go far beyond meeting the minimal requirements to prevent pellagra. For example, robust LDL lowering and HDL raising have consistently required 1 to 2 grams/day or more in clinical studies, a level at which niacin exerts effects similar in magnitude to powerful prescription drugs like statins or fibrates. In this context, high dosing is necessary to engage niacin's receptor-mediated and systemic NAD-driven benefits. By contrast, NR and NMN are used mainly for NAD replenishment. Because they feed directly into the salvage pathway, smaller amounts can raise NAD levels locally or systemically, but they do not engage niacin's unique lipid-lowering receptor targets or offer the same cardiovascular protection. In other words, NR/NMN's lower dosing does not reflect a broader spectrum of activity. It reflects a narrower therapeutic scope. Second, high-dose niacin's clinical track record demonstrates powerful, multi-system effects. It modifies lipoproteins, reduces inflammation, and improves endothelial function, all of which translate into real-world reductions in cardiovascular events, as seen in trials like the Coronary Drug Project. No NR or NMN study in humans has yet shown equivalent benefits on hard clinical outcomes like heart attack or stroke prevention. This suggests that niacin's larger dosing supports greater therapeutic depth, not simply inefficiency. Moreover, dosing scale must be considered relative to what is being treated. For mild NAD depletion in healthy aging, modest NR/NMN doses may suffice to raise NAD levels. But in conditions of profound NAD loss like neurodegeneration, advanced metabolic disease, or systemic inflammation, the multigram niacin doses shown to reverse severe symptoms of pellagra may actually make more sense, given the much greater NAD demands of these pathologies. Importantly, the risk of adverse effects with higher doses must also be weighed, and niacin does come with challenges: flushing, liver enzyme elevations, glucose intolerance at very high doses, and in rare cases, hepatotoxicity with sustained-release forms. However, these risks are well characterized and, for many patients, manageable through careful titration, using immediate release or modern extended-release formulations, or combining niacin with anti-flush strategies, e.g., low-dose aspirin or inositol hexanocotinate. In comparison, NR/NMN's long-term safety in humans at any dose, even the lower ranges commonly sold, remains largely untested beyond small, short-duration trials, leaving uncertainty about potential cumulative effects like methyl donor depletion, since NR/NMN increase NEM burden, or unanticipated metabolic disruptions. Finally, there's a philosophical dimension. When niacin is used at high doses, it crosses the boundary from a mere nutrient to a true therapeutic agent, akin to how high-dose biotin treats certain rare metabolic diseases far beyond nutritional sufficiency. This shift should not be viewed as inherently bad. Rather, it reflects niacin's unique ability to operate at both ends of the spectrum, correcting deficiency at milligrams/day and driving profound pharmacologic effects at grams/day, something no other NAD precursor can claim. Therefore, rather than seeing niacin's higher dosing requirements as a sign of inferiority, it's more accurate to interpret them as evidence of greater therapeutic leverage, a capacity to engage additional molecular targets, like GPR109A, modulate systemic lipids, and correct profound NAD deficits. Niacin's higher doses are not an inefficiency, but a gateway to therapeutic actions that designer NAD precursors simply cannot replicate at any dose.